So welcome everyone. For those of you who joined us only for this session or just for the past two or so, I'm Andre Fernandes, one of the clinical fellows in Trauma and Orthopaedics at the Lewisham and Greenwich NHS Trust, working at Queen Elizabeth Hospital. And with us moderating today, we have Ms. Emma Fossett, a Trauma and Orthopaedics specialty registrar at the very same trust. The topic of today's session will be the neck of femur fractures, the femoral shaft, and the periprosthetic fractures. And the scope of this program is aimed at the junior level, as you know, at the acute management, but not only for doctors, but also for nurses, EMP practitioners, GPs, and so on. As per usual, the program will be run as a no questions asked type of thing per voice, but feel free to type in chat. Emma is moderating. She'll keep answering the quickest and fastest way she can. And by the end, we'll allocate some time to go through every single question, no matter what. If anything changes as an audio and video, just give us a few seconds. It's probably internet related, but we should be fine. The main goals of the session is to go through the basic anatomy and physiology of NOFs, the importance that it is and how big of a high-risk condition it is for the society and for people itself as the patients. We want to teach you how to identify, how to assess, how to stabilize and manage NOFs in the acute setting as well. The NOFs or the hip fractures are the bread and butter of orthopedics. So it's the most common admission into an orthopedic ward. It's a complex medical condition. It's not just a broken bone. So when you look at the numbers, you have more than 75,000, and this number of fractures is only going to go up as the population ages, as the population becomes older and older and more frail, more people will tend to break bones and break hips. It's, as I said, a complex medical condition, not just the bone, and it's associated with a big socioeconomic burden with a lot of money poured into it from the medical, but also the social aspect of it. Now, why do we say it's a complex medical condition, and why is it so important for not only doctors, but everyone involved in healthcare? So the mortality and morbidity is really high. We have a 10% rate. These are studies and backed up by NICE guidelines and everything. 10% of the people with a hip fracture die within a month, and about 30% die within 12 months. These are very high rates for medicine. However, more than half of these deaths are not directly attributed to the fracture. So why are people dying? Why are we concerning? Why are we pouring so much money into the system and try to deal with NOFs in the most concise, expedited way? So we want to avoid all of the complications associated with the inpatient stay, because people die from many different reasons, from cognitive reasons, with post-op delirium being very common, from MIs, from pulmonary atelectasis and pneumonias, from gastrointestinal tract related disorders, from purely protein caloric malnutrition, and so and so. So keep that in mind. Keep that NOFs are complex medical conditions and should be treated as such. As for the anatomy, there's a lot going on in the thigh. There's a lot that should be within your grasp, as in you should be aware, but the most important thing that we should focus on is on the bony aspect of it right now. Because on the acute setting, you don't need to know exactly which muscles insert on which portion of the bone, but you need to know the bone very well. So you know femur, thigh bone, articulating at the hip and at the knee. We've covered the hip with Rory in the previous session, and the knee will be covered on the next session, I think on Thursday. And the femur is the long thigh bone. We usually think of it as a head plus the neck plus the trochanteric region onto the shaft, yeah? Looking a little bit more closer onto the neck itself, as I said, head, the neck, which we called the intracapsular region, so above the line here, plus the intratrochanteric region, plus the subtrochanteric region. So why is this important to us? Why is it that important that we subdivide neck of femur fractures. So it's all about the blood supply. I don't know if you remember from anatomy, or if you don't, there's significant blood supply going to the neck and then to the head anteriorly or proximally from the circumflex artery. So a branch of the femoral profunda with the two medial and lateral circumflexes that then extends superiorly through the ascending cervical artery. So if the fracture happens within the neck, depending on the level, depending on the complexity of it, the blood supply might be disturbed. If it is, it might lead to AVN, meaning necrosis of the head, because if there's no blood supply, there's no nutrition. Even though we do have the small foveal artery, it might not be sufficient, and most likely won't. So most patients on NOFs are brought in by ambulance. You wouldn't have a walking neck of femur fracture. I haven't seen one in my years of practice. So usually brought in by ambulance in a non-weight bearing status with an immobilized limb, with a painful lower limb. They might be confused or not, usually related to the background, to the complex medical condition because of dementia and all of that. As they come through the door, as a primary healthcare professional, an ENP, a nurse, whoever it is, should always think about the mode of injury. You should always think, is this just a NOF, but isolated, non-concerning, or should I be thinking about trauma calling this patient? Now, Rory covered the Atls Protocol very briefly, and he gave you some really good insights onto it. On the right-hand side, there's a table, and there's a lot to consider. So if someone has a NOF, but they have low GCS, why do they have a low GCS? Did they hit their head? Or was it a significant fall, more than, I don't know, a flight of stairs? Or was there other type of trauma associated with it? Is there a lot of bleeds? Was there chest injury associated with the fall? So always think back to the protocol that we have. Always think back to, is it just an off isolated, non-concerning, or should I be escalating this through the proper trauma team? Going back to the basics, history taking, it's very important for orthopedics, and we'll go through in a step matter. So as you're taking the presenting complaint of a patient, it's very important to know where the fall happened. Was it inside or outside? How exactly did it happen? Were there any pre-syncopal symptoms? Did the patient lose consciousness prior to falling? Or did they just trip mechanically and on a patch of grass and fall onto the hip? Was there a long lie? So people that stay in the same place waiting for the ambulance for 10 hours, 12 hours, you're going to have issues, renal dysfunctions. I think Mr. Dutta covered high kalemia and all of that with rhabdomyolysis. And in regards to the post-medical history, you should always try to get as much information as you can, not only from the ambulance, from the patient, which might be a dementia patient, but also the next of kin. The next of kins are very valuable in this situation because they'll know a lot more about the frail group, especially aging population, if there's an elderly patient. So cardiovascular status, anticoagulation medications, from AF, as in atrial fibrillation, all of that, it's very important. And specifically in orthopedics, the social history has a high importance, because we don't want to fix, or we don't want to consider surgery if someone's immobile. Let's say if they're bedbound, why would you fix the hip and put them through surgery if they spend all their time in bed? So the number of aids, do they use sticks, Zimmer frames, and how independent are they? How many carers do they have? Who sorts out the activities of daily living? Do they do their own shopping, cleaning, dressing, and all of that? On examination, usually I always go back to the basics. I always do a quick A to E assessment, no matter how isolated the injury might be. Rule out the head injury and confirm it's isolated. There's no, because we've had a few times people focus on the NOF, but the old lady also has a broken wrist, for example. Even though the NOF's more important, you also need to address the wrist. And then we go for the look, feel, move. That's been many times discussed in our sessions. So we talk about what can we see, what can we feel, and how does it move? When you're looking, is it open or closed? Is there a significant hematoma communicating with the external environment? Is there bruising, swelling, bleeding, or any visual deformities? And when you touch it, how or where exactly is it tender? Is there capitus? Is it mobile? Is there an associated high temperature with it that might make you think about infections? And as for range of motion, it will definitely be restricted in all planes, and there's a few special tests that we're going to mention. And Emma, if there's any big questions by now, feel free to interrupt. Now, as we go through the objective examination itself, look, feel, move again. I've put this picture here, even though it's related to dislocations, it's a very good visualization, a graphic showing you how exactly a limb can present depending on how the hip is placed. So as you're looking, the limb might be shortened, might be externally rotated, meaning pointing outwards kind of, and there might be a bit of a mild swelling surrounding the fracture. The proximal femur is most definitely going to be tender, and there might be some crepitus and swelling associated with it, and the motion is definitely going to be restricted. So in all planes with pain, and one of the tests you can do is axial loading. So by hitting the heel, prompting axial loading, and then prompting weight through the femur, you can try and prompt pain on the hip. You can roll the leg, as in internally, externally rotate. It will be very painful also. And people who are not able to straight the leg raise, meaning elevate the leg off a bed completely straight, they will most likely have a significant fracture. And here we go, a few pictures depicting exactly what I was saying. If you had to think which one is broken, you'd probably go for the right one, as in the right lower limb of this patient, right? I think it's quite easy to spot because it's a short and externally rotated. Same thing here. Probably the left is slightly short and externally rotated. So something might be broken. When I say something might be broken, it doesn't necessarily mean the hip. That's why we need to do a full examination and properly rule out knees, ankles. You don't need, or you shouldn't only focus on the hip. So as we go back to the diagram, I've kept it here just for the purposes of illustrating where you might be able to correlate in the x-rays. What do you think on the left-hand side we're looking at? Do you think this is a subtrochanteric fracture, intratrochanteric fracture, intracapsular fracture? What do you think? I'll give you a few seconds. I think this is a quite easy one, but I'll give you a few seconds to try and reply. All right. I think someone said intracapsular, which is quite clear. So definitely an intracapsular. You can see that most of the femur is as in the rest of the femur is intact. We'll go into the specificities of it, but it looks intracapsular. Well done. Another picture. What about this one? Does anyone have an idea? I think it's pretty easy also to identify this one, but try it out. Yeah, intratrochanteric, definitely. You can see some loosened, see some fracture lines through the intratrochanteric region, as we mentioned. And finally, this one, also pretty clear, also pretty easy, a subtrochanteric. You can see the head looks intact. The trochanteric region looks intact, but as you come distally, here's the fragment, and it's the subtrochanteric proximal femur that's involved. one of the classifications that we do use specifically for intracapsular, it's just worth you guys knowing about it. It's the Garden classification. Depending on how the neck is involved and how broken it is, we classify it as 1, 2, 3, 4. And this might guide our surgical management. The least broken it is, the less likely the blood supply is involved. Just good to keep in mind. And going on to initial investigation. So when we look at an AP pelvis, these are all of the things that we should be looking at. As I said, not only the hip might be broken, the patient might have hip pain, but actually been complaining of back pain radiating onto the hip, or might have a broken pubic rami or an iliac crest or a sacral bone fracture. So it doesn't necessarily mean the hip might be involved when people are referred a patient with hip pain. And I think this is probably the best page on Instagram that I've ever seen regarding medical knowledge. It's The Radiologist, the UK-based radiology consultant that does very thorough reviews. So on Insta, just at The Radiologist, does very thorough reviews of all types of imaging, not only for ortho, but from MRI scans, ultrasounds, abdo, chest X-rays, and even on the description of each post, he puts a lot of information and his systematic approach to formally review imaging as a radiology consultant. So in regard to the hip itself, same thing, same post from the radiologist. These are the things that we look at. So from outlining the cortex of each individual bone, making sure there's no lucencies or fracture lines going through the cortex. Then looking at the neck, for example, trabecular lines of the bone, are they all intact? We have a line called Shenton's line from the medial aspect of the neck all the way around to the inferior border of the superior pubic rami. Is it intact? A few more lines, iliopectineal and the ilioischial line. Are the pubic rami intact? Is the acetabular roof intact? Iliac crest, iliac spine, and the lumbosacral region. Lateral X-ray, always very hard to interpret it, especially because the radiation that you need to give not always is suitable. So the exposure and lateral X-rays are always very poor. But yeah, I'll go back here just for a second. Remember this, because this will be very important for the following pictures. So you've done your imaging, you know where the patient is, you confirm there's a broken bone, fine. What else do you need to do? What else should you worry about? You should do a full set of bloods from FBC groups and saves for pre-op management, but also femurs bleed, so they might need pre-op transfusions, clottings, always worth it, especially in the frail patients. You need to confirm they don't have any abnormalities that need to be reversed preoperatively. And as patients fall and usually have a long lie, or even if they don't, they might just be dehydrated because they haven't been eating or drinking properly. Use an EASE renal profile to assess for renal function. As part of the acute management, analgesia is a very important part of the ED management. It should be provided in ED as soon as possible. It makes it easy to examine the patient, but it's also providing exactly what you need to control the pain on the long term. FIB block means fascioiliac block, which is an injection, a procedure that takes 10 seconds. It might be used with the aid of ultrasounds, but you can do it without still. And it aims at putting an injection, 20 mils, let's say levobupivacaine or whatever it is, or lidocaine, into this muscle compartment, which covers the femoral nerve and the lateral femoral cutaneous nerve, which will numb the leg and provide long or medium to long-term analgesia. That usually allows people to be properly mobilized from bed to trolleys, nursing care to be provided, pain to be sorted, and reduces the burden on opioid medications. Some degree of stabilization should be provided, as in either the patient stays non-weight bearing in bed, or if there's a dementia patient, you might need to provide one-to-one care with a nurse HCA looking after that patient. And then, yeah, you consider referring to ortho for all of the subsequent steps. Sorry. Now on to the surgical management. So there's a few things to consider. As I said, blood supply to the head is very important. That's what determines how and exactly how we want to fix it. If it's intracapsular, we tend to go for hemis or total hips, or fix it in situ with cannulated screws. Intratrochanteric, DHSs, dynamic hip screws, or intramedullary nails, and same thing for the subtrochanteric part of the femur fractures. Conservative, I've only kept it there because remember, you should always think about NOFs as a very complex mosaic, a very complex medical condition, which means if someone's end of life about to pass away the next week due to, I don't know, oncological disorders, why would you get her theater? So you should always consider all of the aspects of the patient and treat it as an holistic approach, as a whole patient, not just a broken bone. And I've put a few pictures here to better illustrate what I was saying. I've kept a table on the side so you guys can keep referencing. So here you go. An intracapsular fixed with a hemiarthroplasty or replaced. An intracapsular NOF replaced with a THR. So the difference between the hemi and the THR, as you can see, is the acetabular component. One's a total hip arthroplasty or hip replacement, and this was half a hip replacement, yeah? This is not very important. One of the decision makers behind this is, for example, the age of the patient. Very young people, we usually go for the THRs, whilst old people, hemis. Cannulated screws, fixation in situ. So looking back to the Garden classification, if something's broken but very nicely in place, just a bit of disruption of the neck, you might consider to just fix it in situ. It's a less invasive surgery, and you might just try and risk it as in, all right, the blood supply might still be intact. Let's not put someone through a hemi and just fix it in situ. So this is one of the options for undisplaced neck femur fractures. An intratrochanteric, this is a really nice picture. You can see the plain film with the line extending there. I'm hoping you can also see it on your screens. So it was an intratrochanteric, which was fixed with a dynamic hip screw. And we have a few subtrochanteric fractures. You can see the fracture lines around the subtrochanteric region, which were fixed with a nail. This is not the best picture because the nail's probably broken also, but yeah, this is a nail with screw fixation to the head. Here's another one, the fracture, subtrochanteric region, nail. I think the previous image was probably just the angulation, but yeah, and the nail going through the whole length of the diaphysis of the bone. Do you guys have any questions regarding this, or should we hand over to Emma to cover periprosthetic fractures?
All right, I think we'll continue with periprosthetic fractures then.
Yeah.
So periprosthetic fractures, they are a fracture which is associated with the orthopedic implant. So as you can see from the pictures, the one on your left-hand side, that's a total hip replacement. And unfortunately, the femur is broken just underneath the implant. If you look on the right-hand picture, that's a dynamic hip screw. And again, the bone's broken just underneath the plate and screws. The fractures can happen around implants themselves. It can happen around plates or any joint replacements. So this is a classification. You just need to know it briefly, really. It's the Vancouver classification for periprosthetic fractures. This is around an implant such as a hemiarthroplasty or a total hip replacement. So you can see just in a basic scale, A is when the fracture is proximal to the implant. So usually involve the greater trochanter or the lesser trochanter. B is where the fracture line is at the level of the stem. So it can be anywhere in that stem pattern. And C is when the fracture is below the level of the stem. We worry quite a lot about B, and that's because when it's fractured in the area of the stem can become loose. Once you have a loose stem, it affects the whole implant, which will mean we'll have to do revision surgery. So basic management of a periprosthetic fracture when you see someone in A&E is you manage them the same way you do as what Andre has been describing for a neck of femur patient. So you do your clerking, you do your usual examination, check most importantly the distal neurovascular status, so the pulses, the dorsalis pedis pulse, check neurovascular status. You can give them the fascia iliaca blocks and you give them adequate analgesia. These are very painful fractures, and it is much nicer for the patient who's waiting overnight for surgery to have good analgesia. For some patients, you may need to give them skin traction. So the x-rays which you saw on the first page, where the bones are actually quite bent, we want to try and save the soft tissues and also try and align the bones overnight. And for this, you can do skin traction, which is this picture on the right. So it involves putting this white foam layer on the patient's leg, then wrapping around it with an elasticated kind of cloth, and then you hang a weight off the edge with this string, and it slowly pulls the bones back into place. But the main thing is it keeps all the soft tissues adequate, because any fracture is going to cause a large soft tissue injury. If we're going to be doing an operation in the next couple of days, we want the healing process to be good afterwards, hence saving the soft tissues. So as you do with all fractures or injuries, you take an x-ray first, and then some periprosthetic fractures, mainly the ones around hip replacements or hemiarthroplasties, we would do a CT scan to further clarify the fracture pattern and to check if the implant is becoming loose or if it's stable, because it does change how we treat them. So we'll go through the management options. So for Vancouver A, that was the one where there's a fracture at the top of the stem. So usually at the greater trochanter or the lesser trochanter. And this is not in association with the stem itself. We'll have a picture now. So this is the first picture. So you can see on the left side, there is a greater trochanter fracture, which has been fixed in place with this contraption called a tension band wire. You could also use something like a metal plate in the shape of a hook, which is called a hook plate. So that's for your Vancouver A's. If you go to Vancouver B picture, please. So you can see with this Vancouver B, the fracture is affecting, it's a spiral fracture, and it's affecting the bottom bit of the stem, actually to probably the bottom 1/3. So for this one, they've kept the stem in situ and have done an open reduction internal fixation, which is using this really long metal plate. And you can see lots of screws. And if you have a look around the middle of the stem, there's this circumferential cable. There we go. And that's a cerclage wire. So it goes right around the bone and just pulls that fracture all back together. Another option for Vancouver B's, as I was saying, we worry that the stem becomes loose. So this one's much more of a kind of a double spiral fracture, affecting about 2/3 of the stem. So you have to assume that that stem is loose. We can't keep that in the patient because it's just going to wobble around. So they've removed that and done a revision using this long stem femoral implant instead. Now Vancouver C, this is where the fracture is below the level of the stem, so we don't think it's bothering the actual stem stability. And for this one, we've done a long metal plate, again with screws, and you can see the circumferential cables, which are the cerclage wires again. When you have a fixation like this, you can actually let the patient either touch toe weight bear or partially weight bear afterwards, because you'll be quite confident that your repair is okay.